Bienvenidos al ciclo especializado de formación, trabajo, salud y estrés realizado por ARL Sura con la colaboración de Prax, el Grupo de Investigación Estrés y Salud de la Universidad de los Andes y el Centro de Epidemiología Social. Este ciclo de formación tiene 4 ejes temáticos, 10 conferencias, 9 expertos de 4 países y equivale a 15 horas de formación especializada. Tenemos la fortuna de contar con 1,586 participantes de 747 empresas de 114 actividades económicas y esperamos que con los conocimientos que ustedes van a adquirir el día de hoy y en el transcurso de todo el ciclo se impacten positivamente las condiciones laborales de 626.388 trabajadores, que son los trabajadores equivalentes a las 747 empresas que nos acompañan el día de hoy. Recuerde que usted tiene la posibilidad de escuchar esta conferencia en el idioma original o con traducción simultánea al español. Para escucharlo en español, simplemente ir en la parte inferior, ahí va a encontrar la opción de interpretación o idioma. Seleccione ahí el idioma español si usted quiere escuchar la traducción en simultáneo, o si lo quiere escuchar en inglés, no hay ningún problema, puede seleccionar el idioma original inglés. Adicionalmente, recuerde que usted puede compartir sus reacciones, comentarios en general a través de la opción chat. Y en caso de que tenga alguna pregunta para el conferencista, por favor realícelo exclusivamente a través de la sección de preguntas y respuestas. Esta sección va a ser monitoreada por mi colega, la doctora Viviola Gómez, quien va a estar recibiendo, analizando y procesando las diferentes preguntas en el transcurso de la conferencia que haremos en la última parte a nuestro invitado del día de hoy. Recuerde que la asistencia va a ser tomada en cualquier momento del evento mediante un formulario que va a encontrar publicado en el chat. A quien asista a todo el ciclo se le entregará un certificado especial de participación y a quien participe en algunas conferencias un certificado por cada uno que serán enviados al correo electrónico de cada participante una semana después de haber finalizado la última conferencia. Adicionalmente, tenemos el sitio web de Memorias, un sitio completamente público. Allí, unas horas después de finalizado cada evento, va a poder ver, comentar y compartir las conferencias en la página de Memorias del ciclo de formación. Y allí mismo, si no lo alcanza a hacer durante la conferencia, va a poder diligenciar la asistencia. No siendo más, le doy la bienvenida y la palabra a mi colega, la doctora Viviola Gómez, del Grupo de Investigación Estrés y Salud de la Universidad de los Andes, quien fue quien construyó la propuesta pedagógica del ciclo de formación que estamos viendo el día de hoy y quien va a presentar a nuestro invitado. Viviola, bienvenida.
Buenos días a todos. Gracias, Sebastián. Voy a tomarme un par de minuticos antes de presentar a nuestro invitado de hoy, porque creo que es importante hacerles caer en cuenta de un poco de la lógica de la programación académica que preparamos para ustedes. Entonces, quiero un poco recordarles a los que han venido participando en las sesiones anteriores que dedicamos hasta ahora 2 sesiones a revisar aquellas condiciones de trabajo que son las que la investigación ha demostrado que son de mayor relevancia a la hora de impactar en diferentes resultados o diferentes variables o diferentes consecuencias, tanto en las personas como en las organizaciones. Allí ustedes ya escucharon a 2 de los investigadores más importantes a nivel mundial sobre, digamos, esas condiciones de trabajo, y recuerden que nos han enfatizado en el exceso de demandas, en la falta de control, el exceso de esfuerzo que hacen las personas y la falta de reconocimiento o de recompensas en términos de dinero, recompensas o estabilidad laboral. También el doctor Karasek nos hizo caer en cuenta la importancia del apoyo social, tanto de colegas como de los supervisores. Esto es para que tengamos en cuenta que estamos como hablando de la parte como de las causas, de las principales causas de problemas, o sea, los principales factores psicosociales de riesgo para la salud y para ciertas variables también de la organización. Vamos ahora a dedicar unas 4 sesiones, si yo no recuerdo mal, a mirar un poco esas consecuencias de diferente índole para la salud mental y física de las personas que trabajan, consecuencias que a su vez tienen impacto en la organización, y también vamos a dedicar una sesión especial a mirar consecuencias para la organización. Entonces, lo que quiero es hacerles caer en cuenta que vamos a estar enfatizándonos en las próximas semanas en las consecuencias o algunas de las consecuencias más importantes, y al mirar esas consecuencias estamos mirando de qué manera se conectan con esos factores psicosociales que hemos estudiado hasta ahora. Allí tendremos la oportunidad de mirar también qué tipo de factores de riesgo individuales son importantes con respecto a diferentes resultados. Por ejemplo, puede ser el caso del género, puede ser el caso de la edad, puede ser el caso del estrato socioeconómico, es decir, variables individuales que pueden en combinación con condiciones psicosociales poner a la gente en mayor o menor riesgo. Sobre eso también estaremos incluyéndolos en estas sesiones, pero lo importante será entender en qué consiste cada problema de salud, porque a veces, muchas veces, a veces o muchas veces no, pero lo que quiero decir es muchas veces tenemos ideas acerca de un problema de salud que no son correctas, pues queremos entender en qué consiste el problema, cómo este problema se conecta con las condiciones psicosociales de riesgo, cómo podemos observarlo, medirlo, prevenirlo sobre todo. No haremos énfasis en estas sesiones en intervención o curación de estas condiciones de salud, ni las condiciones para las organizaciones. Recuerden que luego de estas sesiones vamos a tener unas sesiones enfocadas especialmente justamente en evaluación, medición e intervención de todas las condiciones de salud o del cambio de las condiciones psicosociales de riesgo en el trabajo. Entonces quiero es como que tengan esta lógica clara para aclarar o para precisar las expectativas que ustedes puedan tener de cada una de las sesiones. Dicho esto, me place presentar a nuestro invitado de hoy, que es el doctor Peter Schnoll. Peter es profesor emérito de medicina de la Universidad de California en Irvine. Su formación es de un médico y es epidemiólogo que ha estado estudiando durante más de 35 años cómo las condiciones laborales impactan el desarrollo de la hipertensión y de condiciones asociadas como la obesidad, ¿cierto? El doctor Schnall es conocido en el mundo por saber y por entender muy bien cómo las condiciones laborales han ayudado al desarrollo de problemas de hipertensión y de otras condiciones asociadas, ¿sí? Él tiene un grupo de investigación, un grupo de trabajo con el que compartimos, porque me incluyo en ese grupo de trabajo, con el doctor Ban-Kyu Choi, con Mark E. Dobson, a quien tendremos también en 2 semanas acá, el doctor Arturo Juárez, a quien tendremos la próxima semana, Paul Landsbergis y Ellen Roskam son parte de este grupo. El doctor Peter, además de eso, ha fundado en el año 87 una organización sin ánimo de lucro que se llama el Center for Social Epidemiology, el Centro de Epidemiología Social, que está localizado en Los Ángeles, y desde allí hace una serie de tareas de promoción, de prevención. De hecho, más adelante les vamos a compartir la información de una de las tareas que en este momento el doctor Schnoll está promoviendo, que se llama la Healthy Work Campaign, una campaña para un trabajo saludable. Ustedes van a ver que allí pueden encontrar montones de recursos y de información, por ahora en inglés, que ustedes pueden utilizar para su propio trabajo. Ya más adelante tendremos la oportunidad de darles detalles, pero en el chat vamos a compartir en algún momento el enlace para esa página para aquellos que quieran empezar a explorarla. No siendo más, pues los dejo con el profesor Schnall. Peter.
Buenos días a todos. Tú sabes que soy de Los Ángeles. Me gustaría presentar hoy en español, pero aún no es posible ya. ¿Por qué? Porque soy un estudiante que está aprendiendo español. Es un placer hablar hoy con ustedes sobre la hipertensión y la obesidad, pero en inglés. Let's begin. Okay. Next. Today, I want to talk with you about the epidemic of cardiovascular disease in the world. We will talk about hypertension. We'll talk about obesity. We are going to talk about the role of work in the development of these two health outcomes. And if time permits, I will say a few words about the role of work stressors, cardiovascular health outcomes such as hypertension and obesity, and the COVID-19 epidemic that we are all suffering through today. Next. Cardiovascular disease, as most of you know, is the #1 cause of death worldwide. Last year in the United States, 840,000 people died from cardiovascular disease. Cardiovascular disease is the #1 cause of death in almost every country in the world. It costs a staggering hundreds and hundreds of billions of dollars in the United States to treat cardiovascular disease, and the costs are continuing to increase. Next slide. Among the factors contributing to heart attacks and cardiovascular disease is hypertension and obesity. Almost 50% of all adults in the United States suffer from high blood pressure. And 30 to 40% of adults in the United States suffer from obesity. And all of these changes are occurring in jobs that are changing on a regular basis, some of which are requiring little physical activity, contributing to both obesity and to high blood pressure. Why to high blood pressure? Because obesity is a major risk factor for hypertension. And as people get heavier from lack of activity, their blood pressure goes up as well as their weight. Next slide. Now we're going to focus on hypertension for a few minutes. Next slide. Blood pressure elevation is the leading contributor to cardiovascular disease worldwide. Half of all heart attacks are associated with elevated blood pressure. In China, for example, 50% of all cardiovascular disease is related to high blood pressure. Next slide, please. And blood pressure continues to increase from young age to elderly age, so that in the United States, by the time we're 75 years of age, we have a 70 to 80% likelihood of having hypertension. Virtually all older adults in the United States have high blood pressure. Next slide. And this prevalence of hypertension is continuing to increase in modern society. Each year, no matter what group you're in, white, Black, male, female, blood pressure prevalence is increasing. Next. And this is true, in addition, all over the world. In Brazil, more than 1/3 of all adults have high blood pressure. In Colombia, 70% of adults over the age of 60 have high blood pressure. 7 out of every 10 people. And that number continues to increase as we get older. India, 70 years ago, 1 or 2% of the population had high blood pressure. 3 years ago, it was 30% of the population had high blood pressure. In China, after the Second World War, there was virtually no hypertension. Today, more than 25% of adults have hypertension in China. Remember, China has gone from being an agricultural nation to an industrial nation. People have migrated from farms to the cities. They've gone from being farmers to being industrial workers. And as they've done so, the number of people with high blood pressure has increased dramatically. And we can see the same pattern in virtually every country that is undergoing industrialization. Next. Here is the prevalences of hypertension and the increases over the last few decades. And you see that developing countries are showing more rapid increases in high blood pressure than industrialized nations. Why? The industrialized nations already have high prevalences, and the developing nations, as they industrialize, show increases in blood pressure. Next. Cardiovascular disease and hypertension are epidemics of very recent historical origin. They are diseases of the last 100 to 200 years. Next. How do we know this? We can study cultures, societies in every stage of economic development. This is anthropology, the science of differences by culture. Cross-cultural studies of adult blood pressure, next, can give us clues as to what are the factors that are associated with high blood pressure. Studies by Ingrid Waldron, next. Next. Studies by Ingrid Waldron, a professor of anthropology at the University of Pennsylvania, and her colleagues of many very different organizations, societies, industrialized versus agricultural versus traditional agricultural versus pastoral, where people herd animals for a living and for subsistence, or hunter-gatherers, people who without industrial society. Comparisons show the more industrialized the society is, the greater the prevalence of high blood pressure. Hunter-gatherers, pastoral herders, traditional agricultural communities, their blood pressures are extremely low. This graph shows you that the maximum average blood pressure for men who are age 50 to 60 among hunter-gatherers or pastoral herders is less than 120 systolic, whereas the average blood pressure in a country like the United States at age 50 to 60 is closer to 140 systolic. The difference in blood pressure between these societies is 20 to 30 millimeters of blood pressure, a change that's occurred historically over the past 100 years. Next. The changes in blood pressure parallel the transformations of work. We have gone from a human society, which was primarily agricultural, autonomously based craft work. Remember, our ancestors made things that they needed in shops, okay, tools, craft work. Today, it's all machine-based, including the use of computers. And many of us work on assembly lines associated with mass production. This kind of work on a production line associated with high demands and little control or autonomy is what we call job strain. You were fortunate enough to hear Dr. Robert Karasik speak last week, who is the developer of the demand control model, the hypothesis of job strain, work, high in demands and low in control, production line work, and its association with various health outcomes, particularly cardiovascular disease. Though hypertension, obesity, cardiovascular disease are not the only illnesses that work stressors such as job strain are contributing to. Today, long work hours, hours in excess of 45 and 50 hours per week, a form of demand, an exacerbated form of demand, is also a significant contributor to cardiovascular disease. Last week, the WHO, the World Health Organization, published a study demonstrating, okay, that almost 1 million people die each year who are working long hours, more than 50 hours a week per work per week. This is a very powerful risk factor for cardiovascular disease and hypertension. Next. Next. We see smoking, obesity, hypertension, and diabetes associated with modern society. These illnesses have emerged during urbanization and industrialization. We have more machines, less physical labor, more sedentary behavior, and all of these outcomes in terms of the organization of work are reflective of the way in which our economies work today. We have free trade, we have deregulation, privatization of public services, less government money being spent on healthcare, education, and social security. Those are the fundamental changes of our modern society, and they are related to changing nature of work, which in turn is related to increased stressors on individuals, leading to high blood pressure, obesity, diabetes. Many of the illnesses that we find that characterize our life in our modern society are diseases of recent historical origin, and they are related to the way in which work and our society is organized. Next. This is a reminder of the difference between our modern society and our relatives in the real world, okay? Here's a book by Robert Sapolsky, a very famous American biologist, anthropologist who has studied animal behavior and animal physical health outcomes. And he reminds us that zebras not only don't have ulcers, but they don't have high blood pressure either, okay? Why are zebras so different than humans? Why do humans have high blood pressure, but zebras do not? Well, think about the way zebras live. They wander around the open plains, hanging out with their fellow crowd of other zebras, eating grass, playing, cavorting. Yes, it's true that there are lions, and once in a while, lions will sneak up on the herd and scare the bejesus out of them. They will run like crazy, and most of them will get away. An occasional zebra gets caught, and that's the end of the zebra. But the rest of the zebras, okay, go back to what they were doing before. In other words, yes, they're stressed by the lions significantly, but it's only for a few minutes. And it only happens occasionally, not every day. Whereas we humans work in offices, businesses, factories, where every day we have demands which we need to address, and we may or may not have adequate control over these events. The consequences, that difference between our hunter-gatherer forebears, animals that live on the plains, is that today we are stressed continuously, all day long, hour after hour, trying to satisfy the demands of a hierarchical organization, a business for the most part, which wants us to work harder and produce more every day. Next. Let me give you one example of an occupation which we've spent a lot of time driving, professional drivers. We've studied drivers for many years now. Here's an occupation with obesity, high blood pressure, cardiovascular disease, many, many health problems. We know from studies of blood pressure that when a bus driver goes and walks up the stairs of the bus and gets into the driver's seat, that their blood pressure goes up 10 millimeters of mercury from going from the curb to going to behind the wheel of the bus. And when they're driving, dealing with all of the issues of driving, the risks and the dangers of accidents on the road, the passengers who may or may not be friendly, their blood pressures are elevated during the work time. Many studies demonstrate these changes in the cardiovascular reactions of drivers. Next. When I began my research career almost 40 years ago, working with Dr. Robert Karasik on the Job Heart Project at the Columbia University, I developed a hypothesis that followed from his research and his work, that maybe the reason why hypertension was developing in such large numbers in our society was that people were going to jobs with job strain, high demands and low control, and that this was changing their blood pressure. But the blood pressure that was being changed is not the typical office blood pressure that many of you have experienced when you go to have a health physical checkup with your doctor. We're not talking about what your blood pressure is in the doctor office when we talk about work stressors and its impact on your cardiovascular system. Doctor office blood pressure is a transient measure. Just, once you may go once in a lifetime, or you may go once in a month. And what your blood pressure is during those moments may or may not be reflective of what's happening to your blood pressure when you're working. We want to know what your blood pressure is when you're working. So to study work stressors and blood pressure, we need a concept, job strain, that is a potential risk factor. And we need an outcome, blood pressure, which can be measured that reflects what your consistent and persistent blood pressure is. That requires, next slide. This is the job strain hypothesis. I'm just going to remind you so that you can follow the discussion over the next few minutes. Remember that Dr. Karasik said high demands, low control, low decision latitude, the light blue box at the bottom. This is the risk factor. When you have a job which is demanding, but you don't have adequate control, you don't have adequate autonomy and ability to do the job, you don't have enough say about how you do the job. When you have this combination, he hypothesized in 1980 that this would lead to cardiovascular disease. And my research was, yes, it leads to cardiovascular disease, but the way it does so is by raising your blood pressure and causing obesity. And that high blood pressure and obesity, there are what contributing to your cardiovascular disease and your heart attacks. Next slide. Now, if we want to know what your blood pressure is at work, we don't want to measure your blood pressure in the doctor's office. We want to measure your blood pressure when you're working. And to do that, we needed a scientific development, which came about in the early 1980s, work with Dr. Thomas Pickering at Cornell Medical Center, who was my mentor and who I worked with on this project that we're describing. You see this device in front of you, a blood pressure cuff, a blue cuff wrapped around the arms, okay, and a little device on the hip, which contains a pump, an air pump, and a computer chip, so that it inflates the cuff on your arm and slowly deflates it, measuring your blood pressure. And this device can store the results of the blood pressure because underneath the cuff is a microphone that can listen to your blood pressure. So this device will measure your blood pressure as frequently as you set it to do so, every 15 minutes, every 30 minutes, whatever, okay? And we can collect dozens and dozens of blood pressures over a 24-hour time period while you're working, while you're at home, while you're sleeping, and when you're commuting or doing leisure time activities. Can we go back one slide? One more. Okay, so this is the New York City worksite blood pressure study, which I designed in the 1980s, many years ago now. Its major goal was to study the relationship between job strain. Remember, job strain in 1980, 83, 84 was a brand new concept that had never been studied in terms of blood pressure before. And we did this at Cornell Medical Center in New York City. It involved several hundred men initially, okay, to look at what they told us about their working conditions, and we then had them wear ambulatory blood pressure monitors at work for 24 hours And we were able to compare job strain with casual blood pressures and job strain with ambulatory blood pressures, okay, and see what the relationship is. Next. Next. Okay, so I think you probably all are getting the idea why we were interested, why I was interested in ambulatory blood pressure, but let me just point out a few things about the ambulatory blood pressure. Number one, we are obtaining blood pressures of you, of the person wearing the ambulatory monitor, as you go through your normal life, your normal activities. When you're going to work, not when you go to the doctor's office, but when you go through the things and you do the activities that are associated with your job, your real life, your commute, etc. So we call this a naturalistic form of measurement. We are capturing your real life blood pressure changes, not some artificial in the doctor office blood pressure. These devices are accurate. They provide us with large number of readings so we can compute averages. And for you, those of you who know a little bit about statistics, etc., you know that collecting a lot of readings and taking an average produces a more reliable and accurate result than an occasional 1 or 2 readings, okay? So we get more reliable averages and we get better predictive validity. The measure is more valid. It gives stronger results to psychosocial stressors. Next. Stop. No. So here are some of the interesting results. There are many, many papers that have been written about the New York City website blood pressure study. You can find them under Schnall or Landsbergis if you search in Google Docs, okay, or on Google. Just look for our name and look for job strain and the papers will appear. You can download them, and when we put this presentation up online, we'll provide you some references to some of these studies as well. Here is a very important slide from the first wave. We studied people 3 different times, 3 years apart over a period of 10 years, okay? So we measured job strain and ambulatory blood pressure 3 years apart, 3 times. And here are the results from the first wave of the study. The first time we studied people, we measured their demands and their control. We calculated whether they had job strain or not. And then we associated this with their ambulatory blood pressure, what we found when they wore the device to work. And here's the results. The dark blue bar is their systolic blood pressure. The yellow bar, the diastolic blood pressure. You see, during the day, their work pressure, their home pressure, and their sleep pressure were associated with job strain at a very, very high level of significance. And that the increase in their blood pressure, if they reported to us on a questionnaire about their job, if they said they had high demands and little control and little say over their job, their blood pressures were almost 8 millimeters higher. 8 millimeters, that is a whopping amount of increased blood pressure from telling us that your job is highly demanding and low in control, okay? Next slide. And then this is the consequences. This slide's going to need, it's not appearing properly. So let me help you understand it, okay, because it's not clear. These are the longitudinal results. The results following people from time 1 to time 2. So we got 2 sets of measures. We got your blood pressure and your job strain twice. When you entered the study, we asked you about your demands and control. We measured your ambulatory blood pressure. 3 years later, you came back, we did the same thing, okay? And then these bars tell you what we found with regard to job strain and your blood pressure. The orange bar are the people who told us that they had job strain at time 1, as well as job strain at time 2, okay? Those people who had job strain twice, their blood pressures were 12 millimeters higher than people who didn't have job strain. Repeated exposure to job strain was associated with an increase in your blood pressure of 12 millimeters. And the other groups show the intermediate effects, okay, of having yes and no at different points in time. And you see, if you have yes one time and no the other time, your blood pressure is still elevated, but not as much so as if you have job strain each and every time. And look at this. The people repeatedly exposed, their blood pressure is 140 millimeters of systolic blood pressure. That's abnormal. And the people who are never exposed are 128. That's normal. Next slide. So altogether, over the past decades, when we published this study, and there have been more studies since then, but we were able to review some 34 studies in 2013 after decades of this research, some of which were longitudinal studies like the one I was just describing to you at Cornell Medical Center that I conducted, but other studies, cross-sectional, one-time studies where we just look at one point in time, or sometimes we look multiple times. And next, what we found on average across all these studies was that your blood pressure at work and home was 3 to 4 millimeters higher, and during sleep was 5 millimeters higher for males. Women showed a smaller effect, men showed greater effects, okay? However, all three groups with work systolic blood pressure of 3, 4, and 3 millimeters of increase were all significant. Next slide, please. And here's a summary slide for both job strain and effort reward imbalance. You heard Dr. Johanna Siegrist's presentation 2 weeks ago talking about effort reward imbalance. So two major psychosocial models have emerged that are important. The job strain model, which the New York City, you might wonder, why didn't the New York City study that I first just described to you and not have effort reward imbalance in it? Well, Dr. Johanna Siegrist unfortunately didn't develop his hypothesis till 10 years after we started the research at New York City's Cornell Medical Center. The only hypothesis in 1983, 84 was the job strain hypothesis, okay? Subsequently, there's been a number of studies of both of these, and the overwhelming majority of these studies show a positive effect between these psychosocial work hazards and blood pressure, okay? These findings are more significant for men than they are for women, and that's a whole other topic, which I'm not going to get into in this lecture, but I can answer questions about it in the future. Next slide. So remember, I'm an epidemiologist, so I'm interested in the pattern, okay, of the disease by various causes. And work, organization, occupation, socioeconomic status, gender, these are all important categories. We want to know if men and women are different, if jobs are different, okay, in terms of their impact on people's hypertension and blood pressure. Next slide. So here's a result from our New York City blood pressure study, which we've been talking about. And take the box on the left, the first 3 bars, the blue, yellow, and green bar, and try and imagine that the labels on the top are a little bit further to the left, so that non-manual is over blue, clerical is over orange, and manual is over green. And what this slide is showing you is that manual workers who report being exposed to job strain in our New York City blood pressure study have dramatically higher blood pressure than people who have white-collar jobs, who don't do manual labor. All three groups are elevated, but the people who do manual labor, okay, have the greatest increases in blood pressure. Why? Probably because they have jobs that are more demanding with less control than do people who have white-collar, non-manual jobs, okay? Because we know that the production line, blue-collar work, manual labor is more demanding, is more systematized, with less control. Their job strain is actually stronger job strain than the job strain that the white collar workers have. The clerical, the manual workers have higher demands and less control than do the white collar non-manual workers, okay? So this is also consistent with our ideas about what is a work stressor in terms of job strain. Next. So I want to turn to a very interesting and related thing, that a finding that comes out of this research, which was a surprise, okay? We learned that being exposed to a workplace stressor like job strain or effort reward imbalance, and by the way, there are now 10 or 12 very important workplace stressors that we know contribute to cardiovascular disease, high blood pressure, obesity, but also to mental illness, to anxiety, burnout, and depression, are all related to work stressors, okay? Work stressors play a role in all of these health outcomes. First thing we have learned from all of this research is that work stressors lead to an increased risk of obesity, hypertension, and heart attacks. Second, if you have these work stressors and you have a heart attack and you go back to a job which has these same stressors, you are more likely to get another heart attack. So one of the things that needs to happen in terms of prevention is, if somebody has a heart attack, before they go back to work, we need to assess what their work environment is like, their psychosocial work environment, because if they go back to the same job that they had before, and it is a job with job strain or effort reward imbalance, they're going to have a second heart attack, okay? We also know that hypertension is not necessarily a chronic illness. It can get better, okay? And so therefore, sometimes people are receiving unnecessary treatment because they're not being monitored properly. And finally, we have discovered a very important epidemic, pandemic problem, which we call hidden hypertension. Next slide, please. So we know that when you measure people's ambulatory blood pressures with a monitor, that the average blood pressure of people who have job strain, just one psychosocial hazard, we're not talking about effort reward imbalance and job strain or long work hours, because all of these have cumulative effects, but just job strain alone will raise your blood pressure 5 millimeters of mercury. But how do we know that? We know that from measuring your blood pressure with an ambulatory blood pressure monitor. We don't know that from your going to the doctor's office and having a casual blood pressure taken as part of a checkup. That blood pressure is a one-time event that may or may not reflect what's going on in your work life or in your rest of your life. Yet the way we diagnose hypertension in modern society is using casual clinic blood pressures. Well, what's wrong with that? Why can we not use casual clinic blood pressures? Because they don't reflect what's happening to us during our workday or at home or during other activities. Next slide. I am now going to present a series of slides which show you how ambulatory monitoring has reshaped our thinking about what hypertension really is and how it is caused, okay? If you go to a doctor's office and he measures your blood pressure, or she measure your blood pressure, and they find it's high, okay? They'll tell you you have high blood pressure. If you do that 3 consecutive times over multiple visits. No one should ever be diagnosed with high blood pressure based upon a single reading. You all probably have been to a health fair where your blood pressure was found to be elevated, but then you go to the doctor's office and the doctor says, you don't have high blood pressure, Okay, that was just a transient event of going to a health fair, for example, or because you had a bad day and you were stressed for some reason. If you, however, go to a doctor's office and they tell you you have white coat high blood pressure, you have hypertension in the doctor's office, but then you wear an ambulatory blood pressure monitor, what do we call it if it turns out that the ambulatory monitor doesn't show you to have high blood pressure? And that happens, as I'm going to show you, about 25% of the time. You can go to a doctor's office 3 times and be told you have high blood pressure and wear an ambulatory blood pressure monitor and have totally normal blood pressure. How is that possible? Because when we go to a doctor's office, we're worried about what the doctor's going to find about us and tell us about ourselves. So we're anxious and our blood pressure goes up in the doctor's office, sort of like having a lion, okay, about to jump on you in the woods or in the fields. Doctors' visits are stressful and they can produce transient elevations of blood pressure. If you go to the doctor's office and your blood pressure is normal, and then you wear an ambulatory blood pressure monitor, and that's normal, we call that true normal tension. That's you really have good blood pressure. If you go to the doctor's office and your blood pressure is elevated, and you go to the doctor's office and your blood pressure, and you go to work and your blood pressure is elevated, well, then you have a consistently elevated blood pressure, and we call that sustained hypertension. And then the whole point of this slide, as far as I'm concerned, as a clinician and not an epidemiologist, is what if you go to the doctor's office and he says your blood pressure is normal, but you wear an ambulatory monitor and it turns out your blood pressure is quite high. And that happens about 30%, 20% of the time. In other words, you can go to the doctor's office and he can say, you're okay. And when we put an ambulatory monitor on you, it turns out you're not. And we call that hidden or masked hypertension. Next slide, please. So okay, another slide where the numbers aren't quite right. So let me just explain. I'm trying to give you an idea of how common this problem of hypertension, masked hypertension is. Just look at the 2 lines. One says clinic diastolic blood pressure. That's with DBP. My apologies about this contraction, but you should all know diastolic and systolic blood pressure. If you go to the clinic and your diastolic blood pressure is less than 85, okay, 2 different things can happen when you wear an ambulatory blood pressure monitor. If your ambulatory blood pressure monitor shows that you have elevated blood pressure, then you have what we call hidden or masked hypertension. You're normal in the doctor's office, but you're elevated at work. If you go to the doctor's office and your pressure's normal, and then you go to work and it's normal, that's the 139 people on this graph, then we say, okay, you have normal blood pressure. So what's the problem here? The problem is that 20% of the time, when you go to the doctor's office and the doctor says you're fine, you're not fine. You actually have hypertension if you wear an ambulatory blood pressure monitor. And the same thing is true in reverse, okay? When the doctor tells you that your pressure is elevated in the doctor's office, the top line, clinic DBP greater than 85, you see that there are 55 out of the 79 people have an elevated ambulatory blood pressure. That's great. You're consistent. You have high blood pressure in the doctor's office. You have high blood pressure at work. We know you have those, so we can say, oh, you really have hypertension. But what about the people who turns out they go to the doctor's office and they're elevated, but when they wear an ambulatory monitor, the 24 people here out of 79 who didn't have an elevated ambulatory blood pressure, okay? Those people, okay, have what we call white coat hypertension. And they're being overdiagnosed and they're being treated unnecessarily. So you see, we have 2 different groups of people who are being diagnosed and misdiagnosed for having hypertension because their ambulatory blood pressures are not being taken into account. Next slide. So is this difference, is this discrepancy between office pressure and ambulatory blood pressure really important? Does it really matter if your blood pressure is elevated at work and the doctor doesn't realize it? And the answer is yes. The answer is yes. Look at this graph and you see these arrows from ambulatory blood pressure and clinic blood pressure pointing down. And if you have hidden hypertension, you are more likely to have elevated ambulatory blood pressure and clinic blood pressure. You're more likely to have a plaque in your coronary arteries when we do a scan, okay? And if you look at the bottom line, you'll see that you're more likely to have an increased left ventricular mass. Your heart is going to be thicker and bigger, and that's unhealthy. That is a very substantial piece of evidence that masked hypertension is a very significant problem clinically and cardiovascularly. So all of you people who are out there living your lives, okay, believing that you have normal blood pressure because your doctor says your casual blood pressure is okay, you really cannot be sure that you are being correctly diagnosed. Next slide. Next. Okay, so it won't surprise you if job strain, a psychosocial workplace hazard, is also related to this masked hypertension. And so this slide shows you here that if you have a highly demanding, low control job, you are more likely to be misdiagnosed in terms of your hypertension. You're more likely, okay, if you have sustained job strain, you are 5 to 6 times more likely to be misdiagnosed with regard to your ambulatory blood pressure. Job strain, okay, is an important factor in predicting what your ambulatory blood pressure is going to be like and whether or not you might be misclassified. Next slide. Next. And I see our time is running through, so okay, so we want to use ambulatory monitoring. Next slide. Okay, I want to mention a few words about obesity before we run out of time. So next slide. So after studying ambulatory blood pressure and hypertension for many years, because we knew obesity is a strong risk factor for hypertension, we decided to incorporate obesity into our studies. And here's just a typical slide showing you the obesity in many different countries around the world. And the United States, of course, is the worst. Next slide. And here's the prevalence and pattern of obesity throughout the country every 10 years. And as you go from blue to red, of course, we're trying to communicate to you that the number of people with obesity is going up in the United States. Next slide. Here's the most recent results. All of those red states, those states with red color, are showing 35% obesity prevalences in the United States. Now, remember, obesity is not just overweight. Obesity is when the tape measure, when it goes around your waist, okay, exceeds 30, a BMI of over 30. Okay, so we're not just talking about slightly heavy people. We're talking about people who are really overweight, and that drives up your blood pressure, increases your atherosclerosis, leads to hypertension and heart attacks. Next slide. So why are people more obese? Because work is changing. We're not as active in industrial societies as we were in earlier agricultural or hunter-gatherers. In earlier cultures, we had to work all day long to gather food and take care of ourselves. And it was mostly physical labor. But today, in production line places, in factories, where we have many tasks, okay, which are now automated, and over the last 50 years, they're less and less physical, and there's more and more equipment to help us do things. we have an increase in sedentary work. And that sedentary work is the result of improvements in technology, changes in work organization, labor relations, less unionization, and so there's less opportunity for workers to have a say about how their jobs are being organized and conducted. Next slide. Keep going, thank you. So, stop. So, working conditions, they require less energy expenditure. And on the other hand, if they're very stressful, people overeat. We have a phenomenon of stress-induced overeating in the United States. Now, I don't know whether that's true in Colombia, okay, as well. But we see in Colombia, the prevalence of obesity is going up. So I suspect that work is changing and food intake is changing as well. Next slide. So we make an argument that physical activity is associated with central obesity, having a big waistline. Next slide. And this is just evidence from one of the studies that we've done that, in fact, there's an association between sedentary work and obesity. Next slide. Next. Okay. So about obesity, the evidence that we've accumulated over the last 10 years is that decreased physical activity, low physical job demands are major risk factors for the development of obesity. Un momento. Next slide. And then here's a study we did that's where we found self-reported data. We asked people, did they eat more than they usually do when they're stressed at work? And the answers that they gave us say that if you had high job strain, you were more likely to be obese than if you had other kinds of jobs. Next slide. So, with regard to obesity, a lot of the workforce is overeating as a way of stress coping. And this is also affecting eating behavior in general. Next slide. And then here's a next. Stop. This is a diagram of how psychosocial stressors at work affect risk factors that affect heart disease. And you see that we now know there's evidence that work stressors lead to smoking. They lead to decreased exercise. They are associated with drinking. We know that hypertension and obesity and metabolic syndrome are associated with work stress. So is burnout and depression, sleeping problems, etc. In fact, most of the chronic illnesses of modern society that are part of our lives that we believe, okay, are caused by who knows what, okay, are and do have an important work-related component. Next slide. This is a theoretical map of how all of this goes together. The reference is here, and we'll put this up online if you want to read about it. Next slide. And I see I have what? How many more minutes can I intrude on people's time? Sebastian, 2, 3, 4 minutos más.
Yes, Peter, no problem.
Okay, senor, gracias. All right, so everyone bear with me. A couple of important conclusions, which I hope I've made a good enough case that you would at least consider them as possibly true. Number one, most important, these chronic illnesses, they're not the natural result of aging. You don't get diabetes, obesity, hypertension, and cardiovascular disease simply because you're older. There are plenty of older people without these diseases, okay? But what they don't have are stressful jobs, okay? That's what they don't have. Because if you have stressful jobs, then you're going to develop many of these outcomes. In fact, we have lots and lots of evidence now that the way we've organized our societies, okay, many of us probably don't want them organized the way they are, but the way that our societies are organized, okay, industrialization, urbanization, result in chronic stress, work stress, okay? And those are mediating and moderating factors that lead to all these illnesses. They are the result of the way we have decided to live our lives in the 21st century, okay? And that means treating these illnesses, hypertension, CVD, obesity, etc., is not going to keep people from getting sick. We need to prevent these diseases by changing the causes, including, in the case of hypertension, the working conditions in which people are working, okay? If we don't do that, then the costs are going to continue to go up and people are going to continue to get sick and die or be chronically ill from them. We must have prevention strategies that go beyond the individual to a societal level to talk about the ways in which work is organized. We need healthy work. We need work that doesn't have too many demands, that provides enough control, where effort and rewards are in balance with each other instead of unbalanced, okay? Those stressors can be changed. Next slide. And just to emphasize all of this in the context of the crisis that Colombia and the United States and other countries in the world are following. COVID-19 impacts on those people who are already work stressed much more than other people. Part of the reason why young people don't get as sick as older people is because they have not been chronically stressed for many, many years. We published a paper in the Journal of Occupational Environmental Medicine 3 weeks ago, which demonstrates, okay, that essential workers, people who are doing the critical services, okay, for our society of keeping it function, bus drivers, nurses, okay, hospitality workers, you know, housekeepers, etc. Those people are more likely to be exposed to COVID-19 because of their close proximity to other people, so that they are more likely to be infected. That's one problem. But the bigger problem, and the reason why older people are suffering so much, is that almost everyone who's older in our society has what we call comorbid conditions. You've heard this word probably in the papers, comorbid. They are illnesses that are associated with work, obesity, hypertension, okay, diabetes. If you have those health outcomes, you are far more likely to have a serious response to COVID-19. You're likely to get sick, hospitalized, and die. Why? Why are those risk factors so important? Because they all impinge and compromise your immune system. High blood pressure and obesity as underlying physiological mechanisms have a depressive effect on the capacity of the immune system to respond properly to stressors. There is an enormous relationship between obesity and hypertension and COVID-19. And to prevent future epidemics from having the same devastating effect on older people, we need to reduce those comorbid conditions. We need to prevent high blood pressure. We need to prevent obesity, okay? These are things that are not emphasized in our modern medical programs. Bastante. Thank you. Questions? Sure, there's plenty of questions.
Thank you, Peter. Bueno, muy bien. Muchas gracias a nuestro invitado del día de hoy. Hablar de este tema tan importante. Ahora vamos a darle la palabra a cada uno de ustedes para que escalemos las preguntas que puedan tener a el doctor Peter. Viviola, te doy la palabra.
Ok, Sebastián, gracias. Sí, Peter, aquí hay varias preguntas. Hay varias personas que han coincidido en comentar que el problema de la hipertensión se está observando incluso en personas jóvenes, estudiantes de universidades o niños. Y por eso alguien dice, ¿será que el problema ya existe desde antes de que las personas entren a sus actividades laborales? ¿O si sería conveniente también generar programas preventivos desde los colegios y las universidades? Es decir, yo lo que entiendo es que varias personas parecen tener datos de que hay problemas de hipertensión y obesidad desde edades tempranas y aquí no están trabajando. La pregunta es, ¿qué puede estarlo causando y cómo esto puede empeorar cuando empiecen a trabajar? Si yo entiendo bien las preguntas.
Okay. Can you hear me okay, Laura, Sebastian?
Sí,
So,
we can hear you.
okay, the problem with obesity in young people, okay, is a very good question. And it would appear superficially to contradict the idea that working conditions are a cause of high blood pressure. Of course, I didn't mean to say that work was the only cause of obesity or high blood pressure. Of course, I think it's a very important one, but there are other factors. And literally, of course, with obesity, overeating at any age will lead to high blood pressure. So if I understand the question right, I mean, where do we start in terms of prevention? Of course, in the United States 10 years ago, because it was so expensive to provide physical exercise for children, all the schools eliminated physical exercise programs as part of their curriculum. And of course, what's happened is weight has increased among children in schools more than it did in the previous decades. Children are less physically active. So physical activity is an important part of obesity, and prevention needs to start with a plan for how we can keep people, doing physically active things, healthy things, and also eating properly. The other thing I would say about obesity, because we also see the same problem with high blood pressure, there are many teenagers with high blood pressure and obesity. So why do teenagers get obesity? Why do teenagers get high blood pressure? Well, one reason is they may be overweight. But the other reason is they may share an environment with their parents, which is stressful, okay? One common idea about what caused hypertension, which the research that myself and colleagues have been trying to disprove for the last 40 years, is that hypertension is a genetic disease, or that obesity is a genetic disease. We think that's the furthest thing from the truth. People do not inherit hypertension, okay? No groups of people automatically get hypertension. But how do we know that? Well, first of all, because many people don't have these risk factors, okay? Many do, but many don't. So it's not just genetically determined. It's not something that's an automatic consequence of human behavior. So we need healthier environments for children as well as for adults.
Okay.
So that's my response.
Muy bien. Alguien refiriéndose a los niños dice que se podría reducir la presión arterial en estas poblaciones si se trabajara con su tolerancia a la frustración, porque considera que la baja tolerancia a la frustración podría aumentar la presión arterial y probablemente no sean solamente muchas demandas y bajo control.
Well, that's a good question. I think the answer is no. I don't think frustration causes high blood pressure. Why do I think that? I don't think psychological factors are particularly important in hypertension. We did a very important paper published in 1990. I know it's a long time ago. Richard Friedman was the first author. I was a second or third author on it. In our New York City worksite blood pressure study, we measured dozens and dozens and dozens, as many psychological attributes as we could find in the literature we included in our study. Symptom Checklist 90R, Seligman's Attributional Style Questionnaire, Rosamond's Type A Behavior Questionnaire. You name it, and we included it. And guess what we found? When we correlated all of those psychological measures with ambulatory blood pressure, not one variable was correlated with people's blood pressure. Not one.
I do not believe there's any substantial evidence that psychological characteristics or traits play a big role in blood pressure. I believe it's an environmental disease. The evidence is consistent that psychosocial hazards of the workplace and the social environment, not just work, but also, commuting, where you live, because we know there's a huge socioeconomic patterning of cardiovascular disease. Poor people have more high blood pressure. Poor communities and poor neighborhoods have more stressors. It's more dangerous. You can't walk down the street in many neighborhoods if you're a woman. It's not safe. That has a consequence to your blood pressure because you spend many hours doing those things, etc. Okay.
Ok, Peter, aquí hay varias preguntas relacionadas con la forma de medir o de relacionarse en las empresas con la tensión arterial. Son muchas, espero que el tiempo nos alcance porque hay unas preguntas súper importantes. Una persona pregunta si usted considera que las empresas deben tomar la presión a sus empleados por lo menos 2 veces a la semana.
No, I don't think that's necessary to measure twice a week. I do think you should get a good baseline of what people's blood pressures are when they come to work. I think you need to do more than just a one-time casual blood pressure. I think it would be great to get some ambulatory blood pressures. You can do that with the device we showed you, but you know that there are these wrist devices which you can wear. Okay, sorry, but okay. You probably have seen these. You can put them on your wrist and you can take your blood pressure at work or at home. You should take a number of them and get an average and have that as a baseline. And then on a periodic basis, you should come back and recheck that people's blood pressure is not going up. Because when you come to work, hopefully you're coming from some environment which didn't cause you to have high blood pressure to begin with. You want to know if your current job is raising your blood pressure, okay? So that means you have to measure the cycle. Now, so you measure people's blood pressures at work on a periodic basis, maybe once every 3 months or 6 months. But you also want to measure their psychosocial hazards. There's surveys. Prax, Sebastian Segura, our colleague on this project, they provide surveys that can help you assess whether or not you have these work stressors. Those are important to collect on a regular basis. Probably once a year is sufficient, okay? Because people's blood pressures don't dramatically go up by 10, 20, 30 millimeters of mercury in just a few days or weeks. It takes long-term chronic exposure to produce these elevations in blood pressure. But you'll have other things you can be measuring as well. Your weight, okay? If your weight starts going up on a regular basis, okay, you should be worrying about why you're gaining weight. Is that a factor of your job? Are you being stressed? So there are things that you can collect that give you a warning. Fortunately, for all of us, it takes months and years for these things to have a significant impact on our health. We don't have to worry that, one day, okay, of a stressful job is going to cause us to have a significant change of hypertension or in obesity. Okay, it takes years. What you have to look for.
Okay. Preguntan si una persona presenta obesidad y diabetes, si la empresa debe reducir las actividades que se le asignan, entiendo las demandas, para evitar posibles infartos por acumulación de trabajo que le genere estrés.
Okay, so anyone who has obesity and diabetes is at greatly increased risk for a heart attack. I would want to know if they also had high blood pressure. Okay, so I think it's incumbent on the medical profession, the companies, to assess the overall health status of their workers. It would be very good if they took a psychosocial work history and see if this person is experiencing psychosocial stressors. Because if they have these outcomes, then you want to go back and see if they have the stressors. And if they have the stressors, you should be thinking about some other job for this person. You know, maybe there is other work they can do, or maybe there are things that can be done to make the current job better. You know, maybe it's possible to sit down and negotiate some changes in the job, okay? Or maybe the company will learn, if they assess all their workers, that a huge number of their workers are being made sick by their working conditions. And this should be important to the company for several reasons. Number one, of course, you don't want to be making your workforce sick, but you have to then pay for them if they're sick, okay? If they get chronically ill, then they have more healthcare costs, they have consequences, they have strokes, they have heart attacks, you name it. And then that's something that the company could prevent. So you could have healthier workers who are less sick, who cost you less if you pay attention to their psychosocial work environment.
Ok. Peter, hay muchas preguntas, espero poder alcanzar. Una pregunta es, en esta nueva era donde estamos, donde todas las actividades son muy rutinarias, como el ejemplo del conductor, ¿cómo podemos lograr reducir la hipertensión? Si ya desde el primer momento en que se está ejecutando la actividad aumenta su presión arterial.
Okay, so bus driving is a good example, okay? Hypertension in bus drivers is not an inevitability of driving. It's the working conditions that are associated with it. Listen, people who drive buses in rural areas, okay, outside the urban areas, okay, they don't get hypertension. I misled you a little bit. I was showing you an idea having to do with urban bus drivers, okay? Yes, people in Colombia and Bogota who drive a bus, okay, on those crazy roads with those people running back in front of the bus, okay, or have so many people on board the bus, okay, that every time you hit the brake, you have to worry about people being thrown, okay, and injured, or who harass you as the driver and threaten you and try and steal your money, okay? This is what goes on, at least in the United States, inside with buses, okay? With bus drivers. The job conditions are what determines people's physiological responses. The jobs simply, the buses and the routes need to be designed better. And believe me when I tell you that this is possible. They do not have this problem in Denmark and in Sweden, okay? They have roads that are better designed, passenger, groups that are better taken care of, and they do more to respond to the problems that the drivers have in carrying out their job. For example, in the United States, in our studies of bus drivers in Los Angeles, one of the biggest problems the drivers have is people getting on the bus and stealing from them and threatening them. They have no safety protection. People get on the bus and they say, I'm not going to pay. Or give me your money, bus driver, okay? And what is the bus driver supposed to do, okay? So they don't obviously carry any money with them personally. And then finally, they don't even use money anymore because, why? They don't want it stolen. So now you use tickets and things like that. But still, the bus drivers in San Francisco are physically attacked once per year by passengers. So the jobs are dangerous, okay? And the buses are not necessarily well designed. People go too fast. They may be asked to the drivers may be making up schedule problems, okay? There are too many people on the bus. They're doing dangerous things. They're hanging on the side of the bus. These are all things that stress the driver.
Peter, un ejemplo para todos que tú conoces. En Bogotá hemos medido la tensión arterial de los conductores Y, por ejemplo, los conductores de Transmilenio tienen unas muchas mejores condiciones, no tienen la misma hipertensión que tenían los conductores cuando manejaban en esos buses anteriores, donde no había paradas establecidas, donde tenían que, además de conducir, reclamar el dinero, estar pendiente de que la gente les pagara, etcétera, etcétera. Si las condiciones de los conductores de Transmilenio no son las ideales, pero son mucho mejores de las que eran antes. Y esto es un ejemplo de que las condiciones de trabajo pueden determinar la tensión arterial de los conductores en particular. Jude Fisher, que es una especialista en este tema en conductores, estuvo en Bogotá un tiempo y nos comentaba cómo uno de los exámenes de admisión que hacen para los conductores es medir su tensión arterial. Para ser conductor, uno no puede tener la tensión arterial elevada. Los contratan sin problemas de tensión arterial y sin embargo, 5 años después, la mayoría de los conductores tienen problemas de tensión arterial. Es decir, después de trabajar como conductores, después de 5 años, su tensión arterial empieza a tener problemas, lo cual muestra que las condiciones de trabajo contribuyeron de alguna manera a ello. Pero no quiero yo seguir en esto porque hay 2 preguntas en particular que creo que son supremamente importantes que no puede contestar sino Peter en este tema. Peter, aquí una persona dice, algunos profesionales médicos no recomiendan tener un programa de prevención, supongo que riesgo cardiovascular, porque es difícil tener mediciones reales y unos indicadores que son muy difíciles de manejar. Y también las posibilidades de cumplir con metas es difícil. ¿Usted qué recomendaría a las empresas?
I'm sorry, repeat that question.
La pregunta, Peter, es, parece que algunas empresas y algunos profesionales médicos de empresas creen que no vale la pena tener un programa de prevención de riesgo cardiovascular porque las mediciones no son confiables. ¿Qué crees tú que se podría hacer en ese caso?
Well, use more reliable measures, like ambulatory blood pressure monitoring. That is
Peter,
why.
Peter, perdóname, te interrumpo. Tú tienes el monitor de muñeca, que creo que no lo has mostrado, tú lo querías mostrar hoy, que es una cosa que muchas empresas pueden usar y son confiables.
See, these, okay, that's a problem. These are not as reliable for each measure as an arm cuff is, okay? Their arm cuffs are better. Wrist devices are better than arm cuffs when you take multiple readings, okay? 5 or 10 readings with this device is better than 1 or 2 readings in the doctor's office with a regular cuff. So you make up for the slightly increased variability of blood pressure at the wrist by taking multiple readings, okay? So listen, I'm sorry, but I don't, today there's plenty of methods of collecting reliable physiological data inexpensively, okay? Inexpensively. You do not need to have a medical team, okay, to measure someone's ambulatory blood pressure, okay? You know, we've written protocols for just taking blood pressures with the wrist device. So it gives you a really reasonable reading, okay? Companies can get this data, but the reason for getting it is to keep your workforce healthy and to lower your costs. This is a business decision as well as a person decision.
Ok. Mire, la última pregunta tal vez porque es compleja y por el tiempo, pero aquí hay una pregunta que alguien dice, cuando se observa esta problemática como consecuencia de condiciones globales, como un asunto ligado al trabajo, la alimentación, hábitos de sueño, entre otras, ¿no sería más apropiado generar políticas de salud pública de obligatorio cumplimiento por parte de todos estos actores y dejar de creer en la eficacia de los programas de estilo de vida saludables parciales y atomizados? Y esto se conecta con otra pregunta de alguien que dice que qué piensas de manejar estos problemas con meditación y yoga.
Okay. Well, let me take the second question first, okay? Yoga and all physical activity, physical exercise, relaxation, yoga, meditation, they are all beneficial, okay? And I encourage people to use them for stress reduction when they can, okay? The big problem with many of those techniques is you can't use them when you're at the job, okay? The very moment you really need them is when you're being stressed, okay? So it would be nice if companies would provide break time for people to be able to do stress reduction activities, okay? But even if you can't do them at work when you're in the midst of stress, I think it's beneficial to do them because they have a calming effect on your body, okay? And they will have some benefit. Now, they will not dramatically lower blood pressure of people who have high blood pressure that's work-related, okay? They'll lower it a little bit, but they're not going to make it go away, okay? The other question having to do with world standards, okay? Before we can have world standards, we have to have companies understanding, okay, that what's going on in the workplace is something that they have control over, that they can have some say about, because they're the ones who are creating the working conditions and the work hours. And so if companies are concerned about what those consequences, first of all, they have to know that there are consequences. I believe many companies don't realize how dramatic the consequences of their working conditions are on the health outcomes for their workers. I hope some of the people who are responsible at Sordo Americana for their health policies will be listening to these lectures and understand their health policies should be encouraging, okay, an evaluation of the workplace and work stressors, and be thinking about ways in which work stressors can be reduced. As part of the insurance company should be incentivizing companies to improve their working conditions as a condition of their insurance. There's no reason some companies do that in the United States. You can lower, if your disease rates go down, your cost rate should go down. Your insurance rate should go down if you have fewer sick people.
It's 12:30.
Now, until companies do that, we're not going to get national standards, because companies have to see that this is in their interest and they have to support them, because companies are the most significant factor in policy making. Okay? Individuals must demand this because they come to understand that work is making them sick, and companies need to do this because they understand that a healthy workforce is in their interest. Look at Germany, for example, which goes to extreme lengths, okay, to provide healthy working conditions. They're not unaware of this, and they have lowered their costs. And we need to do that in other countries besides Germany. In the United States, we're a long ways from healthy work. Most companies in the United States have no idea what I'm talking about when I give you this talk, okay?
Ok. Lamentablemente el tiempo se nos acaba. No fue posible presentar todas las preguntas y me presento disculpas a aquellos que enviaron preguntas que no alcancé a presentar. Algunas de ellas van a ser tratadas en otras sesiones, por eso no les di prioridad, porque traté de priorizar aquellas que tenían que ver fundamentalmente con asuntos cardiovasculares, pero algunos de estos temas que ustedes han enviado y que no fueron presentados hoy, tengan la certeza de que van a ser tocados en algunas sesiones más adelante. Finalmente, Peter, muchas gracias otra vez por tu disposición, por tu amor por ese trabajo, por todo lo que haces, por tener cosas disponibles para las personas y para las empresas. Yo les quiero hacer propaganda más adelante.
Tenga un buen tiempo.
Más adelante, Peter va a hacer una sesión con Sebastián Segura en la que van a mostrar páginas donde pueden tener ustedes recursos en las páginas para evaluar o para hacer intervenciones. Eso será más adelante y yo desde ahora le estoy haciendo propaganda de esa sesión porque allí van ustedes a tener un montón de información y de recursos que pueden utilizar gratis. ¿Ok? Buenas tardes. Sebastián, ¿tú quieres cerrar, supongo?
Viviola, muchas gracias. Reiterar el agradecimiento a Peter por haber aceptado esta invitación.
Gracias.
El agradecimiento a ti, Peter, muchas gracias. Un agradecimiento muy especial también a Viviola por la coordinación y el diseño de este programa pedagógico, a Laura por su traducción y a Simón por apoyarnos en todo el proceso de este evento. Recuerde que el otro viernes vamos a tener el privilegio de escuchar al doctor Arturo Juárez, que nos va a hablar sobre burnout. Vamos a entender qué significa esto y pues cómo está afectando la salud y a cada uno de nosotros. Entonces, un agradecimiento muy especial de nuevo a cada uno de ustedes. Recuerden que esta presentación, esta charla queda grabada en el transcurso de la tarde, va a quedar disponible en la página de las memorias y a través del video que queda en YouTube, ustedes pueden añadir comentarios si lo desean y hacer nuevas preguntas. Procuraremos estar mirando y revisando la posibilidad de responderlos. De nuevo, un agradecimiento muy, muy especial a todos ustedes y nos vemos en una próxima oportunidad.